we have with us Dr. Ashish, who's again a medical director and chief surgeon at Nagpal Eye Center for Cornea and Laser Center at Ahmedabad. And he's going to talk to us on another important topic, PTK versus ALK for corneal scars. On to you, Dr. Ashish. You may have to unmute yourself.
Sorry.
What's happened?
Are my slides visible?
Yeah, they are visible.
Yes, slides are visible and you're audible, Ashish.
Okay. Thank you so much, Chitra ma'am, for having me in this beautiful session, things with such senior speakers and faculty. I'll try my best to cover in the next few minutes a little bit about corneal scar treatment. I'm having some trouble with the slide.
Yeah.
Just reshare it again.
I don't. Mr. Sunil, could you help?
Just click on the screen, sir. You should be good to go. Just click on the screen. It's coming.
It's working now. Okay. So I think we all, as corneal surgeons, we all have to deal with corneal scars after treating all the infections, and I think it forms a huge component of corneal blindness. And we do try and treat them with various options. I think in this session, so what do we have to treat corneal scars? I think we definitely have a full thickness keratoplasty, as we have all been doing since many years. And now, since a long time, we have lamellar keratoplasty, also called as deep lamellar keratoplasty, in which we can replace the anterior layers. And of course, if there are superficial scars, we can do a laser PTK. So for this session, we'll be dealing with the lamellar options and the laser PTK, and just have a brief overview of how we can go about treating them. So suppose you have a corneal scar and it is impeding the vision, like this scar, as you can see over here, or you may also have some degenerations which may lead to scarring, or it could be dystrophies also which lead to recurrent epithelial breakdowns and infections. So I think the most important thing is deciding how we will be able to help the patient, whether the patient needs it, because sometimes the other eye is functional and a lot of patients do well with just contact lenses, because it may just be some irregularity of the anterior surface. Once we have gone through that procedure of checking the best corrected visual acuity with the non-surgical options, we can look at the scar in detail, the location, and the depth of the scar, which is important. Nowadays, we also do OCT. We are easily able to see the depth of the scar, which earlier used to be difficult. And with these options, one can decide the treatment protocol. So now for the PTK, I think the most important thing is that we need to limit ourselves to the 100 microns or so. Because if we go deeper, it will lead to more ablation of the tissue, and it may cause other problems, which I'll discuss in the next few slides. So what are the few tips? I think this is a very nice flow chart, which I found in the IGO. And I think when you're treating a scar, it's important to look at the epithelium. Because how the laser will ablate is very important. It's a little tricky to understand. This is another cartoon which explains the same. So if you have an irregular epithelium and if you do the PTK, it will replicate the same, it will mirror the same irregularity in the stroma as well, below the Bowmans. And that again will, the epithelium will have to mask. So how can we reduce it if it is beyond the scope of the epithelium to cover it? So Nowadays, we have access to trans-PRK or trans-epithelial ablation, in which the epithelium itself acts as a masking agent. Otherwise, one would need to debride the epithelium and then do the PTK. And I think most people do debride it as they do for PRKs. So this is just to show an example of, this is a case of a granular dystrophy in which we did a PTK, and you can see this is in the early few weeks when you can still see the epithelium healing and the demarcation. So in these situations, you tend to take smaller optical zones as well, which are fine because you're trying to clear the central area. So the important thing here is to keep in mind that you will be inducing hyperopia, which needs to be discussed with the patient. There are some ways in which you can roughly calculate what to expect. Nowadays, with certain lasers, if you have access, one can still do some modulations in the periphery to decrease this hyperopic induction. And of course, we also have access to mitomycin C, which is usually used by many surgeons and also not used by many. So I think I'll leave this discussion for later, whether to use it with the PTK or not. So this is just an example in which this is a patient of granular dystrophy in which you can see the central clearing, and the patient has been following with us up for the last 6-7 years, and fortunately it has not recurred, although there are a few crumb-like deposits in the center which are not impeding his vision. So more or less for most corneal scars which are limited, in which we would do a PTK, these would be just the thumb rules to go by it. But then there are scars which may be deeper. Sorry, I think with just a few, one slide which I just made to keep in mind for PTK, the cons. One is the recurrence of disease based on the pathology. If it's a dystrophy, more likely to recur. We have to keep in mind herpes simplex. If your scar was due to an HSV keratitis, one needs to take care to give prophylactic antivirals and also maybe follow up the patient for longer. Refractive error I have already discussed, and of course if you over ablate. So suppose if you look at the pachymetry, the general FDA approval is up to 250 microns, but it is, as a standard practice, we recommend that we should keep at least 300 microns of the residual stroma. Otherwise, corneal ectasia also has been reported in these cases. So coming to the deeper scars. So as I discussed with PTK, we are limited to the anterior 100 microns, and it gives very good results. It's non-invasive procedure, non-surgical, no sutures, nothing. With the DALC, we can solve many problems of deeper scars, but then you have to, the visual recovery is longer. It does have all the complications which are suture related, although it does have good results as well for deep pathologies. So these are the options available. One can call it a superficial anti-lamellar keratoplasty, which may be limited to the anterior 250, some say to up to 350 microns. The other option is a hemi-anterior lamellar keratoplasty, and the third is a femtosecond. So I think I've briefly collected from a few colleagues and friends some 1 or 2 cases of SALC and a femtosecond assisted, and I'll briefly take you through them. So this is a case of a 38-year-old male who with a resolved fungal keratitis and with a central scar involving the pupillary area, as you can see in both the slit. So it's very important to look at the slit lamp. I think however much we underestimate, the slit lamp examination would be the key to decide what to do. And of course, in this case, the OCT will guide us up to the depth. So how is it done? In this case, this is a modified microkeratome based superficial anterior lamellar keratoplasty, in which a keratome, a basic LASIK keratome, and a kind of a LASIK flap was made by the surgeon with a deep flap of around 300 to 350 microns. And as you can see, in skillful hands, even one can dissect this LASIK flap and create a free flap out of it. And you can see the underlying bed is fairly clear. There is a slight faint scar, if you can make out, is still over there. So once this is done, one can repeat the same on the donor cornea and put it in the medium and then just place it over the recipient. The advantage of a SALC is that it's a sutureless procedure. You really don't need to take any sutures, but you need to take precautions just like you would in a LASIK flap, or sort of if you get a free cap, sometimes what you would take care to make sure it's well aligned, it's well oriented, there are no striae. You make sure there are no interface irregularities. And then put a bandage contact lens. And you can see this is an outcome after almost 2 to 3 months. And the patient had improved visual acuity to almost 6/12 in this case. So this is a way of doing an anterior keratoplasty with the help of a microkeratome. But there are other instrumentations available in which you do not need to, which make a free flap by itself. So there are ALTK instrumentations available with Moria and other companies. But the only problem sometimes which does occur is a slight mismatch in the size or a mismatch in the shape. And sometimes it may induce astigmatism. And sometimes the orientation, the shape of this microkeratome boost lenticule, as we know, is always meniscus based. So that may also lead to some changes in the shape of the final outcome. So that's where I think the femtosecond, which is far more precise tool available to corneal surgeons, has come handy. I'll just briefly start off with the video from Dr. Sharon D'Souza at Naran Netralaya, in which you can see this is the femtosecond in which they are trying to create almost a 250 micron deep donor lenticule which is mounted on an artificial anterior chamber. The docking is very similar to as you would do for LASIK, and then you start the femtosecond and it creates a flap of the exact same, the precision is better and it creates a full 360-degree flap. And in this case, again, a healed corneal scar, healed keratitis. The only problem with femtosecond in certain situations is that if it's a very dense scar, then sometimes the femtosecond may not be able to penetrate the opacity as well, and there may be some tags left behind or attachments. So that has to be assessed, and nowadays with the help of good anterior segment OCT systems, it's possible to predict. In fact, they also use it to create better flaps. And the rest of the procedure is, I would say, very similar to LASIK, or femto-LASIK, and nowadays quite a few of you must be smile surgeons as well. So that would be very simple. And you can just lift the flap and place it onto the recipient. And again, with all the due precautions, you put a BCL. So this is the basic procedure. This is the slide showing, you can see the attachment of the flap on the first post-operative day. And one of the studies also had been presented from Naran Netralaya, and it did show good outcomes. Although the basic problem sometimes is that one may not be able to cover the complete opacity. There may be some opacity in the stroma left. So some people do recommend that if you feel that there is any irregularity, either after creating a femtosecond flap or there is some stroma, one could also use an excimer to smoothen it or remove the opacity. So that would be like a combination of a FALK with a PTK. So which can also create better outcomes. This is another case, interesting case from Dr. Vikas Mittal, in which there was a patient with a chemical injury which they had treated. Then they did stabilize the surface by doing a SLED procedure, and then they did a femtosecond based ALK. So this is a very beautiful case which demonstrates the use of surgery to be able to create the best outcomes possible for our surgeons, and this would be in a way an ideal way to do so. So I think this was an exceptional case presented by Dr. Vikas, and one can also use it. This is another case in which there was an anti-stromal scar post LASIK, in which they did a FALK and achieved good outcomes. So it has made it even more, femtosecond has made it even more precise. This is one slide which I had seen a long time back, and I asked Dr. Fogla to share it, in which they have done a femtosecond based procedure for a granular dystrophy, which had already, a PTK had been done a few times. So after a certain point, one has to do a transplant, and FALK is far more quicker in terms of visual outcomes and better than a deep lamellar procedure. So what are the advantages I would say of is that there's a lesser variation, although there still may be interface issues in some patients. And of course, the economics is the only problem with the femtosecond. Otherwise, as a tool, it seems to be a very good tool for corneal scars. Thank you very much.
Thank you. Thank you very much, Dr. Ashish. That was, again, another very thorough talk. When you're planning to do a PTK, Dr. Namrata, I wanted to ask you this. Would you look at going for the same depth, or would you like to go a little deeper, as long as you're within your safety limits?
I think I would like to go a little deeper than what my anterior segment OCT says so. And just going by the title ALTK versus PTK, I think we published a paper 5-6 years ago where we compared PTK versus ALTK in cases of Salzmann nodular degeneration. And in those cases in Salzmann, we actually debrided the Salzmann nodules and then did the PTK. And we found that results of PTK were better than ALTK because obviously there were more complications, post-operative complications in the sense problems post-operatively after you do a graft, then after you do a excimer laser procedure.
How is the advantage of FALC over manual as significant as it is in refractive surgery in these eyes with the corneal?
It makes a lot of difference because FALC, if you can do a FALC, then it really gives you a very smooth cut, provided it is not very deep, because as you go deeper, then femtosecond tends to give you a little irregular cuts. But if they are not very deep, then FALC will give you better geometry of the wound, better apposition, and you can, calculate the measurements and do it as opposed to a manual technique. But yes, ALTK also does, automated technique does better than manual. Manual is going to be irregular.
The other thing which I think Ashish spoke about was the size mismatch part, and femto gives you such a nice precision that you are not left with that kind of problem too much. However, in femto also there can be little retraction of the tissue. You should be aware of what kind of pathology you're dealing with. Yeah. But to take care of that thing, what we can do is we can do a surgery like what first case he was showing using the LASIK microkeratome. We would do such kind of thing in 2 steps. So first step, we make a flap and just let it heal. The second step, I would go ahead and do a punch, vacuum punch in whatever diameter I want. And that time, whatever donor tissue I've taken, I take the same diameter there. Hence, we can match both these tissue precisely as we could match with femtosecond laser. Having said that, many times we can get quite nice tapering edges in ALTK, and hence small mismatch can still be managed quite nicely. Dr. Rajesh, you were saying something.
Yeah. I just wanted to add one thing. What I have felt in FALC, the edge-to-edge apposition is much better than SALC when you do with the microkeratome. And because it's a vertical edge, and in a microkeratome you get a
you can't control the geometry of the edge. And
Yeah, and plus, I mean, in Falc, the edge-to-edge apposition is absolutely perfect. It's
Yeah.
a vertical to vertical edge apposition. So, in a couple of cases wherein there are some reports of epithelial ingrowth after SALC, there is no report of epithelial ingrowth after FALC. And whatever experience I have, I felt that, you know, in some mild scarring also, I have been able to do that, and it works reasonably well, provided, as Dr. Namita was mentioning, that it's not very deep. If it's very deep, then it will create problems. Otherwise, FALC, I feel, has an edge over microkeratomes SALC for superficial opacities, as Ashish was mentioning, up to 200 or 250 microns.
And what about mitomycin C after doing PTK? Is there any second thoughts on that?
No second thoughts. I think I use it in all cases.
Yes. Dr. Imanshu, any other question?
No, I think we've covered most of the thing. I think we'll move on with the next topic.